we will move on to our panel discussion. So that was great, Professor Kirby. That was
Thank you.
brilliant and a really good introduction to this next part of the session where we're going to have a discussion. If you'd like to take your seats here.
Thanks, Carl.
As I say, Professor Kirby setting the scene there for the next part of this. We're also joined by Dr. Carl Orr, consultant rheumatologist at St. Vincent's University Hospital in Dublin, who can talk more about psoriatic arthritis. I hope I didn't fall over that, I did a bit, but it's your area of expertise, and you're just going to tell us a little bit more about it, what people should understand about, I guess, the link between psoriasis and this form of arthritis as well. And Caroline Irwin is with us, and Caroline is a patient advocate for many years. You've spent your life battling this condition, but you have found a lot of relief, I think, in the new treatments, and we'll talk about that in a little while, Caroline. But as I say, you have lived with psoriasis for 50 years, and it is, as we've been hearing, that many of you will be familiar in the room with much more complex than a standalone skin condition. Is the associated risk of developing other diseases something that you were always aware of?
No, I never had any clue. All I knew was I had a skin disease. I was covered and never knew anything about diabetes or arthritis, of which I went on to develop. There was no information years ago, which now there is, Dr. Google everywhere. But yeah, I have developed a lot of the comorbidities.
And if you, in terms of managing those comorbidities along with the condition itself, have you found that challenging, or has the support and help been out there to, I suppose, help identify the risks for you?
Well, yeah, but I feel it's, like Brian was saying, you probably liaise better in Vincent's. I go to Waterford to see my rheumatologist. I go to Tala to see my dermatologist. I go to Kilkenny for my diabetes. And I'm like 3 different people. And none of each of the doctors knows about each other. There's no liaison, even though it all stems from my psoriasis. So I think in the future it would be nice to sort of coordinate a lot more. I feel like I'm 3 different people going to 3 different clinics with 3 different diseases.
It's a lot to manage.
It is.
And in terms of when you acquired the diabetes and the psoriatic arthritis, has that been in the last few years, or is it something that you developed at a younger age because of the psoriasis?
I got psoriasis at 9, I had the arthritis at 19, and I was in my 40s when I got the diabetes.
Right, okay. So that's a lot. I mean, you've had to deal, let's say, with a number of linked diseases,
Yeah.
and because of the initial psoriasis, which you and are managing so well. And we will talk about this new generation of drugs that we're seeing that are really making a difference in people's lives. To bring you in here, Dr. Orr, it is your area of expertise. You're a consultant rheumatologist at St. Vincent's Hospital. A third of people with psoriasis, as we heard from Professor Kirby, will develop psoriatic arthritis. So tell us a little bit more about it.
Well, I suppose, Claire, you've touched on it there, that really, this is a disease which is a wide spectrum. The most obvious and visible aspect of that is obviously the skin manifestation, which isn't something that presents a diagnostic challenge typically, okay? But there are other more subtle, if you like, manifestations of it, part of which fall into my domain, which is psoriatic arthritis. We'd like to raise awareness because, of course, we know that those who get diagnosed with psoriatic arthritis earlier have better outcomes because the treatments work better and they've experienced less joint damage by the time they started treatment, but also that the trajectory of that joint damage fundamentally changes if appropriate medication is started at an appropriate time point. So it is a more prevalent condition than we initially recognized. We certainly know, Professor Kirby says, moderate to severe psoriasis, you're looking at about a 30% prevalence over a lifetime risk of developing psoriatic arthritis. Even those with mild psoriasis, though, can develop psoriatic arthritis, and about 20% of patients overall who have psoriasis will develop psoriatic arthritis.
Yeah, and why is it that some patients will and others will not? Are there specific causes there?
There are genetic differences between those who seem to go on to develop arthritis and those who do not, but those genetic differences are not sufficiently robust to allow us to make clear predictions about the path of a given patient individually. And that remains one of the key challenges in managing patients both with psoriasis and with psoriatic arthritis. in terms of predicting their prognosis, selecting an appropriate treatment for them initially, and selecting a plan B treatment should the first treatment not achieve the desired effect. But it's a prevalent condition, just to return back to that. If you compare it to the more maybe better popularized or better known inflammatory arthritis known as rheumatoid arthritis, which many of you may have heard of, we know that the prevalence of that is between 0.5 and 1% of the general population. Whereas if you look at the textbooks for psoriatic arthritis, they'll suggest an order of magnitude less prevalence for those who have in the general community to be diagnosed with psoriatic arthritis. But the truth is probably somewhere actually in between, and that difference is probably explained by the lack of awareness of this important domain of the psoriatic spectrum, psoriatic arthritis, and the lack of biomarkers or ability for us to send away single or combination of tests to check for this, and sometimes the late presentation of a clear manifestation of the disease.
Yeah, talk to us about the signs and symptoms that people who may be currently coping with psoriasis may have to look out for in terms of psoriatic arthritis.
Sure, Claire. So, I mean, if you accept, that somewhere between 20 and 30% of patients who live with psoriasis have a risk of going on to develop, or will go on even to develop, psoriatic arthritis, the index of suspicion just by having psoriasis on its own should be higher. If you have psoriasis that's severe, obviously that risk is higher. If you have psoriasis that involves the scalp, if you have psoriasis that involves the nails, these are things that should make you think my risk of developing psoriatic arthritis as time progresses is higher than those who don't have those manifestations of the psoriasis itself. The overt manifestation, and certainly the red flags that we would see in definitive overt presentation of psoriatic arthritis, is swollen joints, usually large joints. Often we use the term asymmetric. It often involves one side but not the other. But it's important to recognize that these joints can involve any joints because they share the same type of tissue in each of these joints. So that's some of the most important things that people need to be aware of. One other relatively common presentation of this is with a thing called dactylitis, or more colloquially known as sausage digit. This is where an entire digit becomes entirely inflamed, either fingers, toes, thumbs, and often it occurs in more than one digit, and it can occur in a symmetric or asymmetric fashion at a given time. And you'll notice this because you'll have lost the normal skin folds that you would ordinarily observe over the knuckles. And that will be another very common presentation. And often people don't recognize and have been living with that for quite some time before it becomes clear when they see somebody who recognizes it, that that's actually part of the psoriatic spectrum. I would just like to point out before we move on, because there are another couple of important manifestations, and one of them is the inflammatory type lower back pain. I think Professor Kirby outlined the specific features, because back pain, joint pain in general, these are common problems, not necessarily and almost always not attributable to an inflammatory problem of the joints. But the discriminating features that Professor Kirby went through will help us to kind of pick those types of things up. And these are indications that really, if you're having this and you're living with psoriasis, you really should be referred on for assessment to determine whether psoriatic arthritis is a diagnosis that fits with your presentation. One other key point that I should make, and it's something that we've only appreciated more recently, is that actually you can have the diagnosis of psoriatic arthritis without actually having psoriasis. And that's probably attributable to the strong genetic component associated with the development of psoriasis, in contrast to the likes of rheumatoid arthritis. So in contrast to the statistics, for example, linking monozygote twins, these genetic studies looking at twins who obviously share the exact same genetic material, in rheumatoid arthritis, it's only about 12%. So if your identical twin develops rheumatoid arthritis, you've got a lifetime risk of 12%. So that tells us quite a story. And it tells us actually that probably the genetics associated with psoriasis and psoriatic arthritis are much more appropriate to try and make predictions. And because of that, we sometimes make the diagnosis of psoriatic arthritis in a compatible clinical presentation.
Okay.
If somebody has a first-degree relative who has psoriasis, even if the patient themselves does not have psoriasis.
Okay. And when we listen to this and the complexities really of the disease that we're talking about, Professor Kirby, and Caroline saying there, she has to go to specialists right around the country, different specialists depending on, the linked diseases associated with psoriasis. Is it very difficult to manage then in that case for patients who are coping with the skin condition and everything that goes with that? We saw it there in the slides. Many people will be familiar with their own condition they're living with. And then these linked risks, the linked diseases. And how do people do that effectively?
Well, with great difficulty. Caroline said, do we have things better organized than Vincent's? We're lucky. Carl comes to our psoriasis clinic every 2 to 3 months. And in an ideal world, we'd have people who would look after diabetes sitting in the clinic as well. The problem with that is resource. We're lucky at St. Vincent's, we have a severe psoriasis clinic. We've had one for a long time, and we have access to somebody with Carl's expertise. But Carl can't come every week. And the health service, I'm not here to bash the health service, but having multiple consultants in one clinic, if you're a health service manager, doesn't work. He or she wants lots of people seen quickly, and they would regard Carl being in our clinic as a waste of time. Does that make sense? But clearly, ideally, it should be in the one place. And clearly, the rheumatologist and the dermatologist and the diabetes specialist should all be talking to each other regardless. And there is a move, certainly in the UK and some other countries, to have multidisciplinary team meetings and clinics for people with severe psoriasis. And we're slowly but surely getting there. But it is a health resource issue to do that.
We talked about the area of treatments, and you touched on it there, Professor Kirby, when you were speaking about really the great advancements that have been made in the area of treating psoriasis. For you, Caroline, have you been a great beneficiary of that? Has it changed your life in recent years to see these new treatments come on board?
Yeah.
And how have they suited you?
Absolutely. As the Americans say, life-changing, but yes, it has. I did all the other treatments and the sun treatment and all of that, but I'm 20 years now on these new treatments, and I've got my ears pierced at the age of 60. I bought a swimming togs, I wear shorts, dresses, things I never did. I'm almost totally clear, and it's just brilliant. It's not a cure, it's a management, and it manages it well. So I hope they stay working for me.
Yeah, we were talking about the treatments. I mean, it sounds like these treatments are game changing. In your case, did they come with their downsides at all?
No.
Really? So you didn't feel any associated side effects? Because it was something, again, it's interesting to note, Brian, is that when it comes to, because they're life-altering treatments, as Caroline has just
If you read the
there.
side effects, like on a packet of aspirin, you'll never take them. And people do ring me regularly saying, I've been asked to offer this, I'm nervous, I'm scared. But I'm 20 years on, healthy as a horse, really, besides that diabetes and all the other things. But, but no, I'd say go for it. And my psoriasis was so bad that nothing could have been as bad. Yeah. And now that I've got it under control, I never want to go back.
Is that the typical outcome of people who move on to these treatments? And I know they're wide and they're varied, and there's obviously trials ongoing for the next generation. But is typically, have we seen really positive outcomes here, Brian?
Absolutely. For the vast majority of people, even people with severe diseases Caroline has or had, really, I would say, the vast majority of people are well controlled. So if we went back 25 years, there were a lot of people where they lived just psoriasis lives. So everything was dominated by their skin. What job you did, whether you went on an education, how you spent your spare time, what relationship you had. There were various professions that were not allowed, people with psoriasis were not allowed into. So you weren't allowed into nursing, for example, if you had severe psoriasis. You weren't allowed into the army. So John Updike, who I spoke about earlier, was an American novelist. He was turned down for the Vietnam draft. He was drafted but failed his medical because he had severe psoriasis. Not recommended that you should go to Vietnam because you're on these drugs, but my point being, it impacted everything.
And there was an associated stigma.
And there was an associated stigma. And now, almost everybody, I can say in 2023, we have a treatment for them that will allow them to live normal lives. And a lot of people have a similar story to Caroline, where they come back and say, now I take my medication once every 4 weeks, once every 8 weeks, once every 12 weeks, depending on the medication they're on. And I forget about psoriasis for the rest of the time. And that's a wonderful place to be. And if there's something like a meeting like this, our challenge is to actually find the people who are not getting treatment. Because if we can get them...
That's the question. Do you think there's many people, and Caroline, you'd sort of be aware of it, I suppose, yourself, that you're spending so long and maybe so many years of your life coping with this condition that you haven't gone back to your dermatologist, or you don't know Is that potentially possible that you don't know about these new drugs available and the difference they can then make to your life?
I think that's less and less now. I think Dr. Google has helped. Dr. Google has a lot of issues, but Dr. Google does help in terms of awareness. So if we were having this conversation 10 years ago, there would have been a lot of people who would have had maybe 1 or 2 consultations said, oh, they can't do anything. Caroline used the phrase, there's no cure, and I think that's a very down phrase. It's not a criticism of Caroline's thing, but it's a common thing. There's a lot of things that aren't curable. For example, asthma is not curable, but asthma, you can be a top-class athlete with asthma. You can live a perfectly normal life with it, and I would say the same with psoriasis. That even a cure really is you take a couple of tablets or you take an injection and something goes away forever. Most chronic medical conditions by definition don't have those, but it can be managed that it has minimal or no impact on your life. And that's what is available in 2023. And I think, to be honest, just a long-winded way of saying it, I think awareness is out there now that there are good treatments for this. And because of the internet and because of social media, because of Irish Skin Foundation and events like this, knowledge has increased that there are good treatments available.
It's a good news story.
Yes.
But Dr. Orr, to come back to, I suppose, when we're talking about the area of arthritis, are the treatments available there? Has that come on in leaps and bounds as well as what we're seeing in the area of the skin condition?
Yes, analogous to Professor Kirby's story and Caroline's testimony and of her experience with psoriasis and also psoriatic arthritis more latterly. Our experience with the novel therapies has been very, very similar, actually. It's a little bit more difficult for us to do disease activity assessments just because of the complexity of measuring joints and doing blood tests and so forth, whereas we can observe psoriasis clearing very quickly, and we've been somewhat the poor cousins of the dermatologist because we've had most of these novel therapies become licensed for the indication of psoriatic arthritis about 4 or 5 years after they've already been licensed and been used in the clinics by our colleagues in dermatology who have had their hands on them or had experience in them years before we have. But when ultimately they have been licensed and marketed, we've experienced the same as Caroline's testimony for sure. And there are a couple of things that Caroline touched upon that I think are worth just emphasizing. Clearly, it has been extraordinarily efficacious for Caroline, but also, and this is not just a single experience, but actually the experience in our hands, and I'm sure in Professor Kirby's hands, in particular with the biologic therapies, these are exquisitely targeted therapies that modulate or just change how the immune system has been working, and it has been misworking, if you like, it's been misbehaving. And in general, we don't see adverse effects. Compared to the older medications that we've had to use for psoriatic arthritis and for psoriasis, they're tolerated extraordinarily well.
Right. And that's because they're so extremely well targeted.
They're so well targeted, and there's a lot of what we call redundancy within the immune system. So if we can find a key messenger in the immune system that appears to be driving the disease and can target that and make it become inactive, there's so much redundancy, other messengers that can do that same job, that the disease becomes controlled, but we don't leave the patient susceptible to infections and so forth.
Caroline, from your point of view, is there kind of a hangover of trauma there from all the years, I suppose, you spent battling, and you talked about, getting dresses now and getting the ears pierced, and all the years, I suppose, you had to cover up, deal with that, and deal with the stigma that Brian was talking about. Is it easy to come out of that trauma, I suppose, after difficult years?
It is. I don't recognize myself now. My sister even said the other day, I can't believe you're wearing earrings and makeup. It's taken all the years. It's like I have a different life. I'm a different person, I feel, really. It's all new to me now, and I'm 63.
And, when we were talking about the cycle with psoriasis, the stress being a trigger, and then the condition triggering stress in people as well, which can make the condition worse. Is that familiar to you at all now, or have those traditional cycles all but vanished because of the medication, or do you still have to keep an eye on those potentials for flare-up?
No, I think it's become a thing of the past. Even going to buy clothes now, I realized the other day I can go in and try on clothes in a shop. I would never try on anything. I'd just buy it and hope that it would fit, because you'd end up having flakes all over the place. And like I was saying, like I'm buying a dress and I can try it on, and and it's like a distant memory, but it's still there, I suppose. And you'll always be conscious. And some of my children have psoriasis as well, and I'm looking now at my grandchildren, hoping to God that they don't get it. But
do you think the future is brighter for them?
Absolutely. Yeah.
And you just mentioned there, because you were 9 years of age, and I suppose, Brian, as well, you're working with young patients, with all the new medication that we're seeing coming on board now. Are we likely to see, the images that we're talking about there? I know some of them are very severe, that people are living with, having to cover up a lot. I'm sure there's, I don't know, dressings and other treatments involved. Is that now becoming more of a thing of the past when you talk about some people being treated and the skin condition all but disappears?
Yes, is the answer. And I think that's a key point, is that we recognize a concept, and it's called cumulative life course index, but impairment. So where you get hit at various times with all of the traumas that we get in life, and that if you have psoriasis for a long time, it starts to influence all of those things as well. And as I showed, some of the data showed earlier, this does impact particularly on people in their teens and in their early 20s. Life's hard enough if you're 16, and if your skin is covered in this, it's bad. And now we know with aggressive treatment, when I say aggressive treatment, giving people highly effective treatment straight off, that we can change that. And so, we have got teenagers who just go back to living normal lives, and then hopefully won't have the issues with stigmatization, will make the normal choices of profession and choices of relationships and choices of sport that they would have done anyway, and we take skin out of the equation.
So there's plenty of new good treatments available now. Is there a next generation of treatments though coming down the line, and how do you think we will see a difference again, say in 10, 20 years time?
I think the hope in 10 or 20 years will be, first of all, that the present generation treatments that we have, people will get access to earlier. These come with a cost. They come with a cost to the state and to the health service. That will come down. And that people will come, and you may have guessed there's a little bit of trial and error. So we give people methotrexate first time and see whether they tolerate that. And while we try and cycle through these rapidly, the hope will be somebody comes on day one. We'll have a genetic profile in an hour. We'll have various other biomarkers. We'll speak to them and say, that's the drug for you. You're going to go on that drug, and this is what it's going to do. And the evolution of science and the evolution of artificial intelligence and on databases such as the registries that we use is going to come up with all of that information.
And around, access to drugs, are they readily accessible to people now? Are they free? Are they available? Or is there an element that you may be waiting to see the change?
So once you see us, the rate limiting step is getting to see a dermatologist or a rheumatologist. Once you get to see us, I mean, our government has been very good in providing for these medications. All of the ones I listed, apart from one, are reimbursed by the HSE. And therefore, if you have a medical card, there's no cost to you. If you don't have a medical card, they're all covered under the drug payment scheme, so it'll cost you €80 a month. That's not insignificant, but compared to the real cost of these drugs, it's very, very low. And therefore, so for the vast majority of people, this financial bit isn't the access. The access is really getting to see a dermatologist and getting the recognition that you need this treatment and getting expert treatment so that it can be managed.
Okay. Are there any questions actually at this point at all? I think there's a hand up there. Yes, the lady in the red jacket.
Sorry, I didn't get the question.
Sorry, the question was, what treatment are you on, Caroline? If you don't,
It's an injectable I do every month. They come under the umbrella of biologics. There's lots of different brands. My daughter's on one that she does every 3 months. I do mine every month.
And it's an injectable?
Injectable. It's like a pen and it clicks and it's
Mm-hmm.
Is it what?
Methotrexate treatment?
No, that's a tablet formula. I used to find I got very sick on methotrexate. It didn't suit me now, I have to say. But everyone is different.
Okay. No, another question there, this lady.
Just, I suppose there's 2 questions. Is there any link between urate in the blood and psoriatic arthritis? And how do you distinguish between rheumatoid and psoriatic arthritis?
Okay. That's a challenge that we see a lot of the time. So circulating urate levels are used as a biomarker for the diagnosis and then the follow-up of patients with the potential diagnosis in the first instance of gout. Gout presents very differently in terms of the joint pattern of the disease to rheumatologists, and it's usually readily distinguishable on the basis of how it has presented. The gold standard for making the diagnosis of gout would require an aspirate from the joint. That means taking a tiny bit of fluid out of the joint and looking at it under a microscope to find the characteristic crystals, and once you see them, that's the diagnosis. That's the gold standard. Not always done because the presentation is usually so clear-cut that the diagnosis is not ambiguous and is not usually confused with psoriatic arthritis. In respect of the and urate is not a useful marker in respect of psoriatic arthritis, and actually typically is high because those with the so-called metabolic syndrome often run high urates, and that's just hyperuricemia, meaning high urate levels, but it doesn't correlate with disease activity or the likelihood of this being psoriatic arthritis. In relation to your second question, psoriatic arthritis and rheumatoid arthritis is often not easy to discriminate between. It's obviously much easier if the patient comes to you with the characteristics of severe psoriasis or with the nail involvement or with the skin involvement, and if the pattern of the disease is much more compatible, so large joints, asymmetric, and a few of them, whereas rheumatoid tends to present in the absence of psoriasis, for example, but also involving small joints, specific small joints, lots of them, usually quite symmetrical. So there are distinguishing clinical characteristics that help us to discriminate between that, but it's not always easy, and our biomarkers to make the diagnosis of rheumatoid are a little bit better than that for psoriatic arthritis, but they're not perfect, and no test in medicine is perfect. It was in 1973 that it was first mooted by two guys, I think they were in Leeds, Moll and Wright, because psoriatic arthritis and rheumatoid arthritis before that had been considered a single entity. Couldn't identify that there was a difference between these two. So that just tells you how difficult it was. And when they published their first paper trying to demonstrate that there was a discrete entity that they called psoriatic arthritis, fundamentally different to rheumatoid arthritis, there was a lot of controversy at the time. And now we know, years later, that not only is the clinical manifestations between these two disease entities which share some characteristics, they are discrete entities, and the process driving each of them is different. And to conclude on that, some of the therapies that work for psoriatic arthritis do not work for rheumatoid arthritis, and some of the therapies that work for rheumatoid arthritis do not work, conversely, for psoriatic arthritis, telling us a little bit of the story about what we call the pathogenesis, or the underlying molecular cellular causes of the two diseases. But it's not always easy to tell the difference between these two.
All right. Okay, that's great. We've one more question here. This gentleman here with the glasses.
For Dr. Kirby, for somebody who probably couldn't afford to go private, how would they go about actually seeing a dermatologist like yourself?
I mean, you need a referral letter. So the law in Ireland is if you want to go and see a dermatologist, you have to have a referral letter if you're a primary practitioner. It's not just dermatology, any specialist. It depends on the waiting list and where your location is. If you've got severe psoriasis, we're lucky enough in Vincent's, we'll see you within a matter of months. And usually you wouldn't be waiting for longer than a year to come and see us. That sounds pretty awful, but actually it's not that bad in the real sense of things. But ideally, we'd like to get that clearly down, but there are few dermatologists and a lot of demands on what we do. But simply go to your GP and say, I want to be referred to a dermatologist, and they will refer you.
Okay, that's great. I think we may have time. Do we have time for one more question? Just this lady here.
Hi, it's just for Professor Kirby. I'm currently got gut-head psoriasis as a result of a throat infection, and it's happened before. And I'm just wondering, I've heard a lot of talk about removal of tonsils, and I was wondering, is that still considered, and at what point or how many times does it have to occur for that to be considered?
It's a good question. There are two bits to it. One is generally the rule we use, or I use, is that if you've had 2 flares of gut-head psoriasis directly related to sore throats, we would refer you to ENT for consideration of removing the tonsils. And the reason for that is there's good data now that suggests that 50% of people who get flares of psoriasis related to sore throats, their psoriasis dramatically improves or even clears without their tonsils. The flip side of that is 50% of people it doesn't make any difference. So you've gone through a surgical procedure that may be painful. All tonsillectomies carry a small risk of getting seriously ill or even worse. And half the people it won't make any difference to. So my rule is if you've had 2 or more flares of gout psoriasis, they refer you for consideration. And our ENT surgeon, we're lucky, is very aware of that and will go ahead and do it for psoriasis. And generally, they will take out your tonsils if you're requiring 3 or 4 antibiotics a year for your tonsils. But so it's almost a flip of the coin. 50% it can make a dramatic difference to this, and 50% it won't make any difference, and I unfortunately don't know why.
Okay, hope that's of help. We're going to leave this discussion here for now. My thanks to Professor Brian Kirby, to Dr. Carl Orr, and to Caroline Irwin, who's joined us today.